Welcome to MBBS Mastery. This is the second lecture in our gastrointestinal medicine series, where we explore peptic ulcer disease (PUD) in detail. By the end of this lecture, you will have a complete understanding of PUD, including its causes, clinical presentation, investigations, and management strategies. So let's get started. Peptic ulcer disease is a chronic condition where painful sores or ulcers form in the lining of the stomach or the first part of the small intestine. It occurs when the delicate balance between gastric acid secretion and mucosal defense mechanisms is disrupted. The two most common causes of this imbalance are Helicobacter pylori infection and prolonged NSAID use. Other contributing factors include smoking, excessive alcohol consumption, stress, and certain medical conditions such as Zollinger-Ellison syndrome. To understand PUD better, let's first discuss normal gastric physiology. The stomach is equipped with protective mechanisms like mucus bicarbonate secretion, prostaglandins, and a well-regulated blood supply. These factors create a defensive barrier against aggressive elements such as gastric acid and pepsin. When this defense fails, mucosal injury occurs, leading to ulcer formation. Gastric ulcers are commonly associated with impaired mucosal protection, whereas duodenal ulcers are often due to excessive acid production. Now, let's discuss the role of Helicobacter pylori in PUD. This gram-negative bacterium colonizes the stomach lining, producing urease, which neutralizes gastric acid and allows bacterial survival. The resulting chronic inflammation weakens the mucosal defenses, leading to ulcers. In some cases, long-term H. pylori infection can contribute to gastric atrophy, intestinal metaplasia, and even gastric malignancy. Another major cause of PUD is NSAID use. NSAIDs inhibit cyclooxygenase, COX-1, which is essential for prostaglandin synthesis. Since prostaglandins help maintain gastric mucosal integrity, their inhibition makes the stomach lining vulnerable to acid-induced damage. Patients who regularly take NSAIDs, especially older adults, are at a higher risk of developing ulcers. The hallmark symptom of PUD is epigastric pain, often described as burning or gnawing. However, the pain pattern can help differentiate between gastric and duodenal ulcers. Gastric ulcer pain worsens with food intake, whereas duodenal ulcer pain is relieved by eating but returns a few hours later. Other symptoms include bloating, early satiety, nausea, and dyspepsia. More concerning are the alarm symptoms, such as unexplained weight loss, persistent vomiting, GI bleeding, hematemesis or melena, and severe abdominal pain with rigidity. These suggest complications like perforation or obstruction and require urgent evaluation. Diagnosing PUD involves a combination of clinical assessment and investigations. A complete blood count, CBC, may reveal anemia, indicating chronic blood loss. Liver and renal function tests help rule out other causes of dyspepsia. If pancreatitis is suspected, serum amylase and lipase are useful markers. In cases where cardiac pain is a differential, ECG and troponin levels should be evaluated. For H. pylori testing, non-invasive options include the urea breath test (UBT) and stool antigen test, both highly reliable for detecting active infection. Invasive testing done via upper GI endoscopy (EGD) allows for biopsy-based rapid urease test (RUT) and histological examination. Endoscopy is particularly crucial in patients with alarm symptoms or those unresponsive to initial therapy. Management of PUD involves addressing the underlying cause, promoting ulcer healing, and preventing recurrence. The cornerstone of therapy is acid suppression using proton pump inhibitors, PPIs, like omeprazole or esomeprazole, which are significantly more effective than H2 receptor antagonists like ranitidine. Patients with confirmed H. pylori infection require eradication therapy. The standard triple therapy consists of a PPI, clarithromycin, and amoxicillin or metronidazole for 10 to 14 days. In resistant cases, quadruple therapy with bismuth, PPI, metronidazole, and tetracycline is recommended. For patients who develop ulcers due to NSAID use, discontinuation of NSAIDs is ideal. If stopping NSAIDs isn't possible, co-prescription of a PPI or misoprostol is recommended to reduce gastric injury. Lifestyle modifications play an important role in PUD management. Patients should avoid alcohol, smoking, and excessive caffeine intake while adopting a balanced diet rich in fiber and probiotics. Complications of PUD include bleeding, perforation, and gastric outlet obstruction. Bleeding ulcers may require endoscopic hemostasis, while perforations are a surgical emergency needing simple closure, pyloroplasty, or partial gastrectomy. Gastric outlet obstruction, characterized by persistent vomiting and visible peristalsis, may require endoscopic balloon dilation or surgical intervention. Understanding peptic ulcer disease is crucial for any medical professional, as it remains a prevalent and potentially life-threatening condition. A structured approach, starting from history taking to appropriate investigations and targeted therapy, ensures optimal patient outcomes. This concludes our in-depth discussion on peptic ulcer disease. In our next lecture, we will explore gastroesophageal reflux disease, GERD, and its management. If you found this lecture helpful, don't forget to like, share, and subscribe to MBBS Mastery. See you in the next lecture.